I know many people here. When Charlie started talking, I thought it was a Club Méditerranée holiday resort presentation to sell the next trip to us, but it's not what it's like. It's just Charlie himself. He is hyperactive like his father was. And during this week, we will pay tribute to his father's memory. I've known Charlie for 40 years, even before I became an orthodontist, and I would like to thank him for taking us around the globe while he allows us to share our knowledge with you. I studied in Strasbourg, and for my work, I love two things: passing on information to younger generations, and I taught in the university for several years. And now I have my own private practice in Strasbourg and Luxembourg. I'm not going to teach you anything. You're all very good orthodontists with a lot of experience, but I'd like to share with you what really kept me getting up in the morning the last 3 years. When we had the COVID crisis, we got bored, so I wrote down a process which I introduced in an application called OrthoSafe. How to do orthodontics, always being on the safe side. I like to share what I learn with others, with Emmerich, with Catherine, all the people who are with us, around us, and we're really a team with Bilal, Kamel. And this application allows to provide support to people while they are doing their job. For difficult cases, for less difficult cases. But what I'm trying to do is, I've been trying to insert what we learned in the university to train the interns and turn it into a process. There are many cases, more than 1,000 clinical cases. It means a lot of work, and it's an internal messaging system that allows us to reply to everybody. And we said we're going to try and do artificial intelligence. And artificial intelligence found its way into our clinics. It even substituted itself, replaced in some cases, it replaces the dentist. But I want the artificial intelligence to find its way into our clinics, but without replacing us. Maybe you have ideas along the same lines. This is what we have been busying ourselves with for the last 40 years. Every time you try to find Charlie, you don't know where he is. If you are supposed to meet him at 18, he will turn up at 19, at 7 o'clock, 7 p.m. He's around, but if you find him, you're lucky. That's Charlie. It's not easy to start a company afresh, and we were there to support him. I don't know if he needed our support, but we were there, and it was good for us and good for him. That's just a little joke. Now we're going to go into the heart of the matter. What is keeping us on our toes? It's what we do on a daily basis, because when we want to pass knowledge on, it's not all that easy. We sometimes find it difficult to put words on our intentions. Listening means you try to answer the patient's demand and request. So how do you explain to a machine to which you teach an algorithm how to do this? And that is important for the patient. The second key is observing. That's the key for any orthodontic treatment. If you observe teeth, not just with an objective, because everybody's going to have the same goals for treatment. But we realize, last week there was a clinical case that was submitted on the platform, and people had different opinions. We have a kind of forum. People discuss whether to extract the tooth, not extract the tooth, and 30% thought you should extract the tooth. Others said you should extract the molars. Others said you should extract the premolar. And we found that for the same treatment, there might be different opinions. And not one opinion is not better than the others. One opinion is simply better adjusted to the situation. How do we feed the AI, explaining the AI that there are different opinions on the same case? So the therapeutic goals, we all have the same. And then the way to get there is what needs to be discussed in detail. Because when we do a treatment, we know where we go. We have a goal in mind. But intrinsically, we know how we're getting there, except we don't always all get there the same way. So we had to find a simple way to always be in control of what we do. We always work knowing what we're doing. We have diagnosis, we have a treatment plan, but most of all, we need to take in consideration the consequences. When you place a device and you level the teeth and you align the teeth, there are traps you should not fall in. Bilal's work and the whole team's work was to establish protocols. Protocols are there, but they're not everything. It's really knowing how you're going to get there that matters, how you're going to implement your treatment plan. So there are two essential things. We try to teach how to deal with the cause, but in some cases it's difficult. So how to foresee difficulties. And here we have the protocol for the treatment. The sequences are not necessarily one after the other. Sometimes they might overlap. Coordination, arch coordination, optimization, torque optimization. All of this was prepared upstream with the whole team that is working on Genius in order to try and provide as many possibilities so that we don't make mistakes. We want to limit and mitigate the negative consequences. What we're trying to point out here is what are the problems. Identify the need for the treatment, identify the objectives, we know how to do that. But there is one obstacle that we should steer clear of at any time in the treatment. I'll give you examples. For alignment and leveling, we have to be careful with the incisors, retroclination of the upper incisors, the vertical dimension, periodontal tissues that may be damaged because we did too much expansion and then we did not control the incisors' proclination. When there may be periodontal tissue issues or hard tissue issues, increasing the vertical dimension, closing the spaces, proclination of the upper and lower incisors, etc. There may be so many difficulties, and we want every treatment. For every treatment, we want to be able to teach an algorithm on what it is that we need to pay attention. So we set a framework for the different positions, for everything that I've just mentioned, in such a way that we have a framework that we work, within which we work. What I'm saying here is what we do every day. In the clinical case you're dealing with, do you pay attention to alerts? That's what I do on a daily basis. When treatment is submitted, we have different levels. Some people are experienced, more or less experienced, or beginners. But I don't want this to be different. I'm trying to teach the machine to see things that I see with my own eyes, and that's very important. I'm going to introduce a few clinical cases. All in all, these are cases that you see on a daily basis, and I will try with you to have the same evolution. What will allow me to see light, flashing lights, when I treat a case, flashing lights drawing my attention to a specific problem. Here with this case you see that we have crowding with a very tight arch, bad positioning of some of the teeth, periodontal tissue issues, and we know how to deal with that. With the upper incisors are retroclinated, so we're going to straighten them up in order to optimize the torque. And on the mandible, we want to do expansion, and expansion will be the consequence of the expansion, maxillary expansion, and we simply want the tongue to be able to live in a slightly bigger housing. We can breathe better, swallow better. I mean, that's something we've been familiar with for years. Even before Genius, we've been trying to optimize it and focus on a single bracket when the Genius bracket was invented. This is a fairly simple case, but things can go wrong. I'm going to show you the incisors, the smile, and the incisors and you can tell that we have periodontal tissue issues here. X-ray, panoramic X-ray, nothing really special. The rest of the mouth is okay, the bone is okay. And I have shown with very simple lines how to make the calculations. I'm no longer drawing lines on my X-rays, expect for extreme cases, but I know where I am, what I can do, what I cannot do, and how I have to pay attention to. I want to set my treatment goals. I summarize the patient's features, thin face, transversal issues, tight arch, everything I said earlier. So it's a simple treatment. Expansion, genius brackets, with some very specific bonding methods, correction of class 2, overjet correction, etc. And we have to be careful that the patient cooperates. I mean, that is essential. And don't overlook that. We're not dealing with machines, we're dealing with human beings, and they have moods and compliance issues, and that's important. So back to the table. In the table for each patient, I have shown the alert points. The sequences are the same: alignment, leveling, expansion. You know the sequences. But what here I'm making a difference between what is easy and what deserves my attention. And what's the danger? Well, overdoing the proclination of the incisors, not solving the overjet. The curve P has been shown so that for each patient we can achieve a good curve of speed so that we can calculate the crowding and solve the crowding. We can deal with the class 2 and the diagnosis is there. So artificial intelligence can do the diagnosis. Sometimes it's not totally right. It's still learning, but it can give you a diagnosis about the crowding, the curve of speed, the offset, the discrepancies, etc. And now I have to ask myself the question: how do I control my incisors? Those are alert values. We know the principle ever since Damon developed it, the principle of a force and optimization, distally and not mesially. Positioning the stops is absolutely essential. We've sort of overlooked it, but I think it's important because we're going to stay away from problems that you need to be solved otherwise. And I'm talking about chain and a module. It's the elastic module that we're using or have been using to control our lower incisors. And I'll try and show you how I place it in an S position so that it will optimize the incisor control, but also because it's going to help us level up the curve of speed. We're also going to use bite blocks. Bite blocks are not receiving the tribute they deserve for everything they do for us. I don't like our bite blocks behind the incisors, but at the beginning of treatment I think they make things worse. But bite blocks are something that will move during the treatment, and we need to be capable to use them properly to optimize the result. Leveling the curve of speed, we will see that later, correcting the face, the class 2. I always control my lower incisors and the S-shape, the chain from the beginning to the end. Even with an O18, I use them sometimes, only when it's needed, but careful. Otherwise, you have a bowing effect. I mean, all of those who have worked with lingual orthodontics know what I'm referring to, the bowing effect. The force is too high and the lateral sectors will go inwards, and you end up with something wrong. This is the S chain, the S-shaped chain. It's transparent, but that's what it does. And please pay attention. You have to take the whole caspid. Even if it's going to disrupt the wire expression, you will see with a self-ligating bracket that you really have to be careful with the caspid. there will be a rotation on both molar and the cuspid. So very light forces here to bring the molar forward, but it's held. It gives you the feeling that it's going forward. It's held in place. Then progressive forces here on 4. On number 4, you have an intruding force, and then you hold everything with the cuspid. And people say, yeah, but it's not really doing anything on the incisors. True enough, but it does provide a force. Even like when you're riding a horse and you're trying to rein in the horse with the reins, but you're holding the whole horse. The horse can push its head forward, but you're holding the horse back. And that's exactly what we do here with the chain. It's little spaces created distally from 32 and 42. And you can see that it creates space. It facilitates alignment, and it allows you to bring everything back in the right position. So careful with the biomechanics. Yes, the molar may advance, but it may also rotate. And when I talk about a light chain, that's because it's difficult to quantify how much we allow and how much we don't allow. When we use it, we have a perception, and we're thinking, how can we control this in such a way that the movements will not be parasite movements? It happens in the cuspid, it happens with the molar, and we hope to quantify them when we give an indication with 1 space, 2 spaces. We don't like wide chains, and we don't want empty links that will not be used. Here the patient was even too cooperative. She was wearing elastics all the time. I mean, that's fine. That treatment was performed in Luxembourg. And in Luxembourg, when you say A is A, and B is B, and C is C, and they even go to D, because they're over-cooperative. But at least you get a good result. Here she has used her class 2 elastics too much. It's almost the end of the treatment. You don't need to take pictures before you remove the bracket. We take the pictures because we have to send them to the Social Security for reimbursement. Here, this is the result before I remove the bracket, and look at the movement we have achieved. Look at how the lower incisor was controlled. It was slightly proclinated, but that's okay. Oh, there's one thing I did not talk about, the growth pattern, high angle, low angle. That's going to be included in the algorithm, but I couldn't talk about everything at the same time. I just want to keep the message simple. So here we have corrected the overjet. And look at the x-rays. Everything is perfect. The cuspid is not perfect, but that's okay. And that's the final result. This is on the day we remove the bracket. The tooth morphology has changed a little bit. It's not quite the same as the other side, but look at the expansion. It's perfect. No extractions. We might have been tempted to extract, but because the patient was very cooperative, and the fact that we used the Genius in the best possible way with everything it can give us, elastics, modulus, the chain, the patient cooperation, the magic of the Genius system. And the Genius system is not just a bracket, it's you plus a bracket. It's not just a product, it's the way we use it, you use it. If you use it in an optimal way, you can reach very good results. Here I have done again what Damon was doing. And it shows the patient how much expansion can be achieved. When you see a mouth, people say, yes, but no, here we have something that will be perfect. Genius optimizes the way arch wires are used, it optimizes your prescription, and it encourages all the muscles to achieve this kind of result. This is a simple case, but with all the help and with everything we did, everything we introduced as safeguards, the result is quite satisfactory. These are results that you're familiar with. The second case, somebody knows this presentation because I've already made this presentation in different settings, but sorry, bear with me. This is a case that I like to show because there are two things happening here. the will to try and help this young lady. She doesn't like to smile because of her smile. She has a very forced smile. She's depressed. And she comes to the clinic and we look at her teeth. There's a class 3, lots of malpositioned teeth, not enough space. She's 25, maybe 26. Jean-Baptiste, forgive me. We should have done surgery, alignment, and correction. But we're going to do the same thing. Look at the smile. This is a headache. We really don't know what to do. We look at the X-ray, class 3. Not too much upper incisor proclination, that can be controlled. And these are the elements: a thin face, bad smile, a lot of crowding, the class 3 edge on edge incisors. I mean, the situation is complex. And we think, okay, maxillary expansion surgery and then everything is easy. Except that when you have a patient who's already having psychological disorders, woke up late and came to the clinic in a stressful situation, he wants to be helped. And you tell the patient, okay, maybe I can jump out of the window on the 4th floor, or maybe I can try to do everything else. So I list the issues: expansion, increasing the spaces, increasing the vertical dimension. I have to be careful because already her teeth are barely touching, let alone overlap. I need to level up the curve of speed. Okay, that is going to be easy because if I retrocline the incisors, class 3 incisors might make things worse. And according to the protocol, we reverse the elastics. We reverse the brackets, on the mandible in order to prevent the risk of excessive retroclination. And we have the class 3 correction to deal with. And because I pay attention to emotions, I said, okay, let's do this. But in this case, I will control and check expansion every day. I check whether the bone is holding up or whether the suture is opening or not, so that I can achieve a good result. Bracket flipping so that I can anticipate torque and obtain root buckle control on the upper incisors, and careful with the lower incisors so that they don't proclinate too much. And we don't want incisors that go on a horizontal position. And careful, because we have ways to optimize the treatment, but we have to be careful. S module on the mandible and the class 3 correction. These are the Genius system indications. You can see here that we have opened up spaces with a maxillary disjunction, and we're starting to make enough space here. I don't want to remove the blinds too early, and I continue activating it during the alignment phase, because once disjunction has been achieved, I know she's an adult, and her bone remodeling, her bone turnover will be slow. So rather than this being a disadvantage, I want to turn it into an advantage. Very slowly, I will continue activating the disjunction device so that during the bone remodeling in the intermaxillary suture, I need to wait. I don't want to close it immediately. I will close it, but eventually. Alignment, class 3 elastics. We moved from this arch to this arch, from a very tight maxilla to a much better maxilla. This is the initial situation, the final situation. I see this patient on a regular basis. When patients are going through a different time in life, in a world where being beautiful is more important than being a good person, it's okay to have such a patient, and it's very pleasing, and she comes to me once a year and the results are very stable. Look at her smile before and her smile afterwards. Look how the maxillary expansion how helpful maxillary expansion was in this case. Here we had a phase. She had piercing done. She's wearing a ring in her nose, as if the beautiful smile was not enough. She's adding stuff. And this is the X-ray. Look at the control we have achieved. I'm showing a little brain with a pen, because some people like to trace lines on X-rays, but that's fine. I don't. Here we see that things are getting better and better. Even the stripping is, sorry, not the stripping, even the piercing in her nose and lips have changed. That's her face before and after. So changing the smile, I keep saying, and I learned that from one of my mentors, Dr. Surfati in Strasbourg, who specializes in aesthetic dentistry. He used to say that there are two white areas in the face, in your eyes and in your teeth. These are the two lights in the face, and if you remove one of the two, it's dark. If you restore light in one of the two, then the face will lit up, and patients will feel better, will be more confident. So how was this achieved? Simply because we were able to say not only it's important that we have a good treatment plan, that we can set the objectives, know exactly who we're talking to and who we're looking at, and what the motivations are, and that we have listed all the traps, the pitfalls, so that we can be safe and not end up with something that is not well controlled. And I'd like to introduce a third case, and this will be my last case, because Fanny is not here to say I only have 5 minutes to go. Oh, don't worry, she's here. If you see a case like this one, you need to check a number of things. You have to analyze the available space versus the necessary space. I mean, that's something you learn in dental school. I remember coming to the US many years ago. I think it was like the last 2 or 3 years after Merrifield. He was a Tweed contemporary surgeon. I used the Tweed system at the time. And this is about anticipating the movement. How much space do I have? How do I manage the space? It's not just looking at the patient, saying, oh, yeah, it's going to be okay. Yeah, no, it's going to be okay. And then you go in and you see that you have issues, there's not enough space. So you've closed the spaces too early. And so here you have to be careful. When we did the X-ray, we saw that there was an issue. When you are looking at this kind of picture, you tell the mother, it's going to be okay, relax. And then all of a sudden you see the X-ray and you say, well, it's not going to be okay, I'm sorry. So please make sure you anticipate. Anticipating means that you see that she has an impacted cuspid. Okay, that happens. But mostly, here you have to wonder, am I going to move the premolar first and then the cuspid, or maybe something else? I will not show you the CBCTs, but here in this case you have to think, can I get through or not? And if I were to ask your opinion, half the room said there's enough space to get through, the other half will say no, there's not enough space. Oh, we have an issue. Analyzing the space requires to know what you want to do. You have to close your incisors to make them safe, and you have to bring down the impacted cuspids. And so you also have to place the brackets at the right time. If you bond them directly, you're going to have issues. You keep solving issues, so be careful. I'm a little agitated, so I decided to put everything back in place. And look, the tooth was going into the right position, but it was the beginning of root resorption. I'd like to tell you something I learned from Professor Bacon in Strasbourg. Maybe you know him. He used to say, and he knew everything about this root resorption. He studied the root resorption extensively, and he's published extensively. He said there is always root resorption. And the key word was, that's how he said it. He said, root resorption is the healing scar of orthodontic movement. Regardless of the tooth you move, if we were able to do a microscopic study, we would see that there are signs of root resorption. It's okay. It's not too bad. You can tell here the things are okay. And that the root is stable. I may have lost 2 millimeters, but the root is stable. And the patient will be able to chew. It doesn't mean that if you replace a premolar with a cuspid, it's perfect, but sometimes you have no other options. And so here, this is the patient at the end. When we close the space, everything is managed from the beginning. And here the problems were not too serious. The main problem was to correct the swallowing process and correct the tongue position. And AI cannot see that, not now. In the end, AI should be working for us and not replace us. It should help us save time and find the pitfalls you need to stay away from. And that's what I've been doing in the last few years. Clear the ground in such a way that we can reach predictable results, well-controlled results, and not tell the patients we don't know whether we're going to achieve a good result or not. We have to be in control of what we do, and we have to predict what we want to do, and that's fundamental. Thank you. I think I've kept to my allotted time, but that's it.
Now, with Charlie and Emeric and Bilal and Catherine, everybody here in this room and also working, it's like a wedding. You know, Charlie's getting married every 6 months, and we just help every time. Every time he travels, we support him as if he was getting married. It's an organization. So we love Charlie, we love ARIEL, and we're all very busy people. We never really stop. But this is also what we are passionate about. I'm 58, and I think that maybe in a few years' time I will retire. But deep down, I know that I will never retire. I know that till the very end, I will try to always provide better results to my patients. I will try to make the most out of my failures. You should not be afraid of failure, because thanks to failure, you learn. I put that birds on the slide because Orthopartner has to do with teaching and sharing an expertise. I'm not saying that I'm an expert, but sharing experience, helping others in order to prevent those people to fall into traps. It's like skiing. I suppose that you've always seen someone skiing very quickly down a slope, and I'm always fascinated by those skiers. They're upstreams on the mountain, they're very concentrated, they like that. They like that literally. They are super concentrated. And in reality, what are they doing? Well, in his head he knows where the snow is harder. He knows where the trees are located. He knows where he may fall. So what he does is just concentrate, and that's pretty magical. And they do the entire downwards slope exactly with this motion. And this is what I want to do. I want to be sure that what I plan is really going to happen. We are going to celebrate Christmas pretty soon, and for those of you who are going to go skiing, well, enjoy the ride. Thank you.